Now I will present my topic. First of all, I will introduce myself. I am Dr. Mayada Mohammed Ahmed Aldankali, a consultant in obstetrics and gynecology and assistant professor at Rajhi University in Saudi Arabia. I has over 25 years experience of clinical and academic experience. I am specialized in high-risk pregnancy, aesthetic gynecology, infertility, and advanced obstetric ultrasound. I hold an Arab board in obstetric and gynecology, and I am an associate member of the Royal College of Obstetricians and Gynecologists. I published a peer-reviewed research and presented at international conferences, and I'm an author of a book titled A Guide in Critical Care Management of COVID-19. I am recognized among a pioneer Arab women leaders in health and medical education. So I am happy to be with you today. Yes. Yeah. So my presentation today is a very rare case of spontaneous ovarian hyperstimulation syndrome at term pregnancy presented in early labor. Ovarian hyperstimulation syndrome is a rare, iatrogenic, and life-threatening complication of infertility treatment with various preparation of ovulation induction drug, mainly by gonadotropins. Spontaneous form of OHSS is extremely rare and occurs without fertility treatment with or without pregnancy. Van Wyk and Grumbach in 1960 first published a spontaneous ovarian hyperstimulation syndrome in a young girl with juvenile hypothyroidism, precocious puberty, and multicystic ovaries. Ovarian hyperstimulation typically appear from 8 to 14 weeks, a spontaneous form, but the iatrogenic form appear earlier from 3 to 8 weeks and resolve spontaneously. The incidence of ovarian hyperstimulation is 5 to 10% of mild cases and 0.2 to 1.2% of severe cases. There are only one published case of ovarian hyperstimulation syndrome presented at term pregnancy, managed conservatively, and end with a successful term live birth. Reported by Tokmak Etkin et al. At 2015. This case presents the second ever reported spontaneous ovarian hyperstimulation syndrome at term pregnancy during early labor. The exact etiology of spontaneous ovarian hyperstimulation remains unclear, and it occurs in cases with multiple pregnancy, molar pregnancy, fetal and placental triploidy, hypothyroidism, polycystic ovaries, and high level of anti-Müllerian hormone and human chorionic gonadotropins. Schmidt and Bazur et al. In 2003 were the first who described a mutation in FSH receptor as a possible cause of spontaneous ovarian hyperstimulation syndrome. Later on, Deliner et al. In 2006, he made a classification of spontaneous ovarian hyperstimulation syndrome according to the clinical presentation and the presence of FSH receptor mutation. The first group was correspond to mutated FSHR cases. The type 2 correspond to high level of HCG, and type 3 is related to hypothyroidism. The pathophysiology and pathogenesis of a disease is not well studied also, but there are observations said that the overstimulated ovaries due to activation by human chorionic gonadotrophin, release a number of vasoactive mediators, mainly vascular endothelial growth factor and many pro-inflammatory cytokines that cause the pathophysiology of a disease with increased vascular permeability and extravasation of fluid into the third body space, and manifested in the presence of ascites, pleural effusion, hydrothorax, and pericardial effusion. Royal College in 2006 classified ovarian hyperstimulation syndrome according to the severity of symptom into mild, moderate, severe, and critical form. In its severe form, OHSS can lead to serious complications and it may be fatal. And there are reported cases of fatal cases after OHSS by Ishri. In its severe form, due to extravasation of fluid and accumulation in the third space, there will be hypovolemia, hemoconcentration, increased coagulopathy, and diminished circulation into the kidney, leading to oliguria, anuria, and renal failure. There are complications also of ovarian hyperstimulation due to ovarian torsion or cyst rupture. In its mild and moderate form, it can be managed conservatively, while the severe form needs supportive care to maintain intravascular volume, prevent damage to the kidney, and prevent circulatory system, and maintain coagulation function. Our case is a young 20 years old primi gravida, 38 weeks of gestation. She has regular cycle, married for 11 months. She has no any history of ovulation induction or fertility treatment. There is no significant past medical or surgical history. Pregnancy was uncomplicated till 36 weeks, and she was followed by antenatal clinic. And she presented to my clinic at 38 weeks, complaining of abdominal pain, abdominal distension, nausea, and nausea during early labor. On examination, she was a young, healthy woman with average build, normal body height and weight, and normal vital sign. Her abdomen was distended, tense, tender, with irregular contour lateral to the fundus. Fundal height was 34 centimeter, lie longitudinal, presenting cephalic. Uterine contraction were 2 per 10 minutes, 20-25 seconds. Fetal heartbeat was active, 150 beats per minute. On pelvic examination, cervical os was dilated 2.5 centimeter, effaced 50%, membrane intact, vertex presentation at -1 station. Ultrasound finding done, and it shows single intrauterine alive fetus, cephalic presentation, biparietal diameter corresponding to 36 weeks. Fetal heart rate was 145 beats per minute. Amniotic fluid adequate, placenta fundal mature, and the estimated fetal body weight by ultrasound was 2,750 grams. Ultrasound finding also show enlarged, bilaterally enlarged ovaries with multiple follicles of our cystis of variable size. The right ovary measuring 8.6 by 8.4 centimeter, and the left ovary measuring 9 by 6.1 centimeter, and there is no ascites detected. Diagnosis of mild to moderate spontaneous ovarian hyperstimulation syndrome at term pregnancy during early labor was made to this patient according to the classification criteria by Royal College, which define OHSS as mild, moderate, severe, and critical. So the mild form only, there is abdominal bloating, mild abdominal pain, ovarian enlargement less than 8 centimeter. The moderate form, there is moderate abdominal pain, nausea with or without vomiting, abdominal distension, and ovaries from 8 to 12 centimeter. And the severe form was the bad one, that she has clear fluid collection, ascites, and pleural effusion, and oliguria, hemoconcentration, hypoproteinemia with ovarian size more than 12. And the critical form is the most worst one, with increased hematocrit more than 55%, leukocytosis, anuria, thromboembolism, and acute respiratory distress. Our management was, patient was referred to maternity hospital for conducting or monitoring delivery. Laboratory test, initially CPC, liver and renal function was normal. Conservative management with fluid and monitoring labor progress was held in hospital. Next morning at 7 a.m., she gave birth of healthy, alive male baby, 2,700 grams, and discharged 2 days post natal without any complications, and follow-up ultrasound then which show ovaries return to a normal size after 4 weeks. In literature review, we review the literatures of spontaneous ovarian hyperstimulation syndrome that end in successful term live birth or successful term pregnancy. And they show that they are all having early onset. So there is extremely rare to find a term pregnancy, to find OHSS in a term pregnancy due to early onset of a disease or due to adverse pregnancy outcome. So most cases reported early OHSS, most of them end by missed abortion or induced abortion or preterm birth that is iatrogenic or spontaneous due to severe maternal condition. However, the rare cases of spontaneous ovarian hyperstimulation syndrome that have a successful term pregnancy are reviewed here, and I divided them into 4 groups. The first group are those with ovarian hyperstimulation without unknown etiology, started by Ihan et al. At 1996, ending by Kantarasi et al. At 2021. And there is cases associated with increased level of HCG and the cases with hypothyroidism and polycystic ovary. And the last one are those with diagnosed with mutation of FSH receptor. So here we will review in table. This table shows all the cases of ovarian hyperstimulation syndrome that have successful term pregnancy. But as it is clear in the table that all are diagnosed in the first trimester, except our Tokmak Etkin case in 2015, the only one published case that have late onset at third trimester at 37 weeks. So with different type of severity of symptoms, they end in term live birth after conservative and supportive management. Ihan, the first one at 1996, he has his case with severe ovarian hyperstimulation at 12 weeks, and she was having hydrothorax and has severe ascites, paracentesis done many times, but he did for the patient laparotomy for cyst excision and aspiration of ascites that was a misdiagnosis. He thought that his patient was having ovarian cancer. For that reason, a high suspicion of OHSS should be considered in pregnant women in order to prevent unnecessary surgical intervention. Okay. Other table are those associated with high level of HCG. As it is seen by Zhuangji, 2019, HCG was more than 200,000 in his patient, but in spite of that, conservative management then paracentesis or bilirubin then for hydrothorax, and she ended in successful term delivery. Also, again here, all the onset are early in the first trimester. There is no onset in third trimester. And Suzuki has reported a positive family history of OHS in his patient that she has 2 times attack of OHSS in 2 different pregnancies in the same patient and another attack with her sister. But all are started early in first trimester and in at term with ovarian regression mainly occur either at the end of the first trimester or by the second trimester. Rarely to find ovarian regression after birth. Another table presents also cases associated with hypothyroidism and polycystic ovaries. We have Olaton Poussin at 1987 report the first case of spontaneous ovarian hyperstimulation syndrome that end in a term live birth. This is the first case end in a term live birth, but also the onset of a disease was early in the first trimester. And there is also positive family history and recurrent attack of ovarian hyperstimulation syndrome in this patient in 4 pregnancies, 2 ending in a term live birth, 1 ending in intrauterine death, stillbirth at 41 week, 5 days, and 1 end by missed abortion, and it was a severe form. There are some cases report association of more than one risk factor, like Dietrich, who has his case diagnosed with FSH mutation, but also has hypothyroidism and history of epilepsy. The last table is for cases with FSHR mutation, which are diagnosed by DNA, PCR DNA of peripheral blood sample. Here, Gilliam Smith and Vazor et al. Are the first one who report FSH receptor mutation in patient with the spontaneous ovarian hyperstimulation. And he has also recurrent 4 times attack of OHSS in the same patient he followed. But they end also in a term pregnancy. Again, here we see that the onset of a disease are early in the first trimester. So in the literature review, there is only 1 case report late onset at 37 weeks, and there is another case by Battle report onset at 28 weeks, but unfortunately ended by intrauterine death and premature birth, not reach a term. Our discussion is spontaneous ovarian hyperstimulation syndrome, usually present in the first trimester, and ovarian regression occur by the end of first trimester or third trimester, rarely to progress after that. Term onset is only reported by Tokmak Itkin at 2015, and he published his case. This is the view of cesarean section of Tokmak Itkin case that has bilaterally enlarged ovaries with multiple cysts. He discovered this in his patient, was young, 28 years old, and she has followed her pregnancy regular, and there is everything was normal up to 36 weeks. After that, she came to him at 37 weeks, and he discovered the bilaterally enlarged ovaries. Patient managed conservatively. He gave her also coagulation prophylaxis, anticoagulant therapy by Clixon, and also he planned for her delivery by cesarean section at 39 weeks due to fetal microsomia, and she gave birth of a live female girl, 4,000 kg, 60 grams. Our case is unique in that it was diagnosed during early labor and not during the antenatal care. Clinical evaluation and ultrasound are key for timely recognition. Favorable maternal and fetal outcomes are achievable with conservative management. Here we present a table comparing our case from Tokmak case. Presented of a disease here is at 37 weeks, here at 38 weeks, already in labor. Management was conservative. Tokmak gave his case anticoagulation because discovered at 37 weeks and delivered at 39 weeks. Our case came already in labor, so anticoagulation given postpartum. Delivery by cesarean section at 39 weeks due to fetal macrosomia. Delivery was normal, spontaneous vaginal at 38 weeks of our case. Cyst interruption, Tokmak do cyst drilling by electrocautery during cesarean section. but we do not any intervention. Resolution by 2 weeks for tokamak case and by 4 weeks postpartum of our case. Conclusion that spontaneous ovarian hyperstimulation at term pregnancy is exceptionally rare. We present the second reported case worldwide and the first case manifesting during early labor. Our case is published in Gynecology to March 2025. Diagnosis relies on high index of suspicion, clinical examination and ultrasonography. With proper supportive management, excellent maternal and fetal outcome are achievable. Awareness of this condition is crucial for the obstetrician to ensure timely diagnosis and management at any gestational age. Our recommendation that individualized care will provide optimal tailored management for high-risk women. Supportive therapy is the cornerstone of treatment and improve quality of life. Utilizing ultrasonography are invaluable tool for diagnosis, monitoring, and also follow-up, mainly by Doppler ultrasound. Maintain high clinical suspicion is essential for early diagnosis and preventing potential morbidity. Thank you. Thank you so much. This is the barcode of this published case, if anyone interested. William Hart. Yeah. Okay, William Hart.
I'll call the person as well.
Okay.
Please join. Please.
Welcome, Doctor. It is my pleasure. Thank you, bro. That now for question. There is no question.
Discussion. Yeah, we'll ask. So any questions?
Thank you, Dr. Mayada, for your amazing lecture and wonderful presentation. I have a question about the case which was need a laparatomy for cystectomy. One of the cases mentioned. Is cystectomy was done or what?
Yeah.
Because as we know, the ovarian hyperstimulation usually with fluid. How cystectomy was done?
في واحد مفقود بس I have cystectomy is not a treatment. Cystectomy is not a treatment plan of cases with ovarian hyperstimulation syndrome, but that was a misdiagnosis by one author, Ihan et al. He think that his case was having ovarian tumor, and he do laparotomy, exploratory laparotomy, and do cystectomy with also aspiration of ascites fluid, and then the result come show luteinized thecal lutein cell. So after histopathology, he know that it was ovarian hyperstimulation syndrome, not
okay. I mean,
so there is misdiagnosis.
Yeah. Okay, if there is ovarian hyperstimulation, there will be multiple follicles or multiple cysts.
Yes.
Is he cystectomy? I think this is oophorectomy. I remove all the.
Yes, but he write like
Yes.
that in his article.
Thank
It is
you.
written like that in his
Thank
article.
you.
Any question? Yes.
Thyroid studies.
Yeah.
Thyroid studies.
We did thyroid studies for your patient.
Thyroid then normal.
There we go.
Yeah. Yes.
Is there data on risk of recurrence?
Yeah, there are many published articles show recurrence in some patients. For example, today we have around 4 to 5 articles with patient with recurrence. It is presented in tables. There is data, yes. But most recurrent cases was associated due to either hypothyroidism, FSH receptor mutation, or polycystic ovary. That was the cases with recurrency.
As we finished early, we'll have some discussions there and we'll go for lunch.
Now we have discussion or finish.
We'll have discussion sometime.
Okay.
For 20 minutes or something. Then we'll go for lunch.
So we open discussion for any question.
Wondering about is there a standard testing for FSH receptor mutation?
Yes, for FSH receptor mutation, they take a blood sample. Most of the cases diagnosed after they improve, and they take a sample, or after birth, they take a sample from blood leukocyte and testing the DNA sequence of, and they find the mutation.